Hello, hello, hello. Thank you for joining us. Hi there, thanks for joining us. We're going to start the dermatology talk in just a few minutes, and I thank you for joining us tonight. Tonight we're going to talk about dermatology, and this is one of the ways that I've used many times in the past for my students to kind of help them along and for them to be able to really nail dermatology, because they can be a little bit discouraging, it can be a little bit scary, it can be a little bit confusing. So one of the things, if you're studying for your boards, what I would say is maybe turn it off now, maybe listen, but what you can do after we're done with the recording is turn off the sound, and all the slides are numbered, and kind of give yourself a quiz. So you can do 1 through 40, write down on the piece of paper what you think the answer is or what the rash is that you see, and then watch it a second time with the audio on, so you will be able to get a little bit more feedback about what's going on in the slide. So here we go. My name's Dr. Jennifer Klimek Yingling, and the name of this lecture is Name That Rash, Dermatology, and this will be recorded so you guys can watch it again on the Facebook page. Okay. I'm just going to be able to get my slide going here. Okay. All right. Number 1, what is this? Okay, this is actinic keratosis. This is often present on sun-damaged skin. You'll see it on the head, the neck, the upper trunk, sometimes on the extensor surfaces of the arms. Usually this is a precursor to squamous cell carcinoma, and that's why we really jump on this disorder and treat it, because we want to take care of business, because if we let it go, this can turn into the squamous cell carcinoma. What does it look like? As you can see, it's usually a round, dry lesion, usually on a pinkish erythematous base. It looks like it's white or yellow, scaly. Can be tenderness, sometimes isn't. Can be a few millimeters, and it can go into some confluent patches, as you can see in that left side. One of the clues you're going to notice with this patient, you're going to see this a lot if you're down south, people who are out in the sun and have had photo damage. Okay. How do we treat? Cryotherapy. You can use 5-FU, and they also use a surgical shave removal of cartilage. What do you think this is? Okay, this is impetigo. Okay, anytime you see honey crusted exudate, I want you to think about impetigo. This can be very superficial, or it can be bullous, meaning it can be big lesions. Usually if it's very just a slight rash, you can use the Bactroban or gentamicin. If it isn't, you're not concerned about MRSA, you can use a first-generation cephalosporin, and you may use an oral cephalosporin if it is bullous. So this is impetigo, really contagious. You want to do some anticipatory guidance, wash the lesions 2 to 3 times a day, not the same washcloth, lots of hand washing, and you want to use your topical agent or an oral agent. Again, there's mupirocin, Bactroban, or you can actually use gentamicin ointment too, that covers MRSA as well. Or if you're not concerned about MRSA, you can use a first-generation cephalosporin. What do you think this is? Okay, this is tinea capitis. You're going to see this. It's going to be a circular rash with some central clearing. It can be itchy. This is a fungal infection. Your school nurses are going to be all over this. So if you're in primary care and family practice especially, you're going to have a lot of kids come in with ringworm or tinea capitis. How do we treat this? Okay, we use griserfulin. All right, and before we start anybody on that, you're going to make sure that you check their liver enzymes. Okay. They also may use topical Lamisil too. How do we test for fungal infections? We use a KOH preparation. Okay, that's what we use to confirm the diagnosis. And when you do the KOH preparation, you're going to see hyphae if it is fungal. Okay. What do you think this is? All right. This is Acne Rosacea, and the history is going to be the patient may tell you that they had a hair patch, and then and you'll see the picture of that on the right hand side of the screen, and it almost looks like tinea. Okay, you'll have a dry center, but it's going to be a secondary rash that comes that's really going to clue you in, because when the second rash comes, it can be itchy, and it's going to be in a Christmas tree pattern on the trunk. Often it's almond, salmon colored plaques. If you hear hair patch, Christmas tree pattern on the trunk, I want you to think about pityriasis rosacea, and this usually goes away just as fast as it comes. Okay, what do you think this is? Right, so this patient may give you a history that they were in the Rocky Mountains, they were hiking, camping. They may have told you that they had fever for a couple days, and then a rash appeared after 2 to 5 days. This usually is itchy, flat macules. It's usually on the wrists, and then it'll move to the trunk. And then around day 6, they're going to get the red or purple petechiae to the palms and soles. This is caused by the wood tick. All right. Doxycycline is the first-line treatment for adults and children of all ages. Okay. Rocky Mountain spotted fever. Okay. All right. What do you think this is? This is erythema multiforme. Okay, these lesions, what you're going to see, they look pretty bizarre. They're a little bit target-like, lots of them. Usually symmetric, as you can see on the picture on the right. It's on both hands, both legs. Usually you'll see it on the extensor surfaces of the body. This is caused usually by the herpes simplex virus and Mycoplasma pneumoniae. Usually the rash is fixed for 7 days. This is self-limiting, and usually it'll go away on its own. All right, number 7. What do you think this is? Name that rash. What do you think? Okay, this is secondary syphilis. We know with primary syphilis that the patient will have a painless chancre. It'll go away. They think all is good. They may have not even known they had it. But then you may have a patient come in that has a rash to the hands and on the palms and in the soles. Anytime you have, especially an adult patient with rash to the hands, on the palms and the soles, you need to put syphilis in your differential diagnosis. Okay. What are we going to do? We're going to run an RPR, a VDRL. This is secondary syphilis. How are we going to treat? We're going to use Pen-G. An alternative to the penicillin G is doxycycline. Little mnemonic, penicillin G equals genitals. Okay, that's one of the ways that I remember the treatment for syphilis. Keep in mind the RPR is cheaper than a punch biopsy, so you want to do the RPR first. Okay. There are some disorders too to keep in mind in your differential diagnosis. Anytime you have any rash to the palms, the soles, you want to think about Rocky Mountain spotted fever, syphilis, endocarditis, hand, foot, and mouth. Okay. All right. Number 8. What do you think this is? Okay, this is psoriasis. Okay. This picture is a good picture because it really does look like they have silvery scales. You hear silvery scales, you see silvery scales. I want you to think about psoriasis. This is a chronic condition. It's basically old skin that forgets to shed. These patients will have frequent remissions and exacerbations. This is usually bilaterally, so it'll be both elbows, both knees. How do we treat this? We use an emollient. You can use coal tar. You can use topical steroids, phototherapy. They may, if it's a severe case, they may be on systemic medications like your Humira or your methotrexate. Now with psoriasis, if you're going to be testing, there's a couple things you need to pay attention to. So with psoriasis, there's two different things that you'll see that can happen. There's the auspis sign. So if you were to take one of the silver scales off, what you'd see are little tiny pinpoint bleeding underneath that scale. That's called auspitz sign, A-U-S-P-I-T-Z. The other thing that you can see too is if, say, a patient has psoriasis and perhaps they fell and they struck their elbow, and on a line of trauma, you may see in a patient with psoriasis that they will end up with psoriatic lesions that develop on that area of trauma, okay? And it can be from linear exposure or irritation too if they're itching as well. And that's Koebner phenomenon, Koebner phenomenon, Koebner phenomenon. Number 9, what do you think this is? This is kind of fun, right? Okay, this is contact dermatitis. Okay. Anytime you see something that has a pattern, this might be a patient that has an allergy to zinc or nickel, and they had a, one of these costume jewelry and they wore it. So especially if you see something with the shape, I want you to think about contact dermatitis. How do we treat this? You want to avoid the triggers, and we're going to use the topical steroid. Okay, what do you guys think this is? All right, this is folliculitis. Okay, this patients may come in and tell you that they're having razor burns. It'll be itchy. If you have a patient that tells you that they were on vacation and they were sitting in a hot tub, this is a common thing called Pseudomonas folliculitis. How do we treat this? We're going to use the mupirocin, your Bactroban, 3 times daily for 7 to 10 days. If the folliculitis is, severe, or, you're having a hard time getting it cleared up, it's pretty persistent, you may want to use cefixolin or your dicloxacillin. Why is that? We know with non-purulent skin infections, we use diclox, penicillin, or a first-generation cephalosporin. Okay, your Keflex. Okay. Here's another one. What do you think this is? This is hidradenitis suppurativa. Okay. This is basically chronic folliculitis. You're going to see this in the groin, the axillary area, the genital area. It causes scarring. You're going to see that with these patients, they're going to have recurrent abscesses with tracking. It often is in the ages of 18 to 39. What are some of the things we're going to do for our patients? So, and it is associated with diabetes and Crohn's. And it makes sense because we know with Crohn's that these patients can end up with some tracking and abscesses in their GI tract. So with these patients, you're going to have them avoid shaving. You're going to think about lifestyle changes, weight loss. If they're, pre-diabetic, you're going to want to try to see if you can have them change their diet. If this is a mild case, you probably use your topical antibiotics, some warm compresses. If it is moderate, or you're seeing a lot of purulent discharge, you probably need to think about MRSA. And an easy way to remember the drugs that we use for MRSA is MRSA, last letter is A, and then I think B, C, D. So Bactrim, clindamycin, doxycycline. Those 3 drugs cover MRSA. Okay, MRSA, B, C, D. All right. Name this rash. What's going on with this patient? Okay, this is a paronychia. Okay, you're going to see this in patients who bite their nails. I've seen patients come in who have had artificial nails put on, and they've gotten an infection. If they cut their cuticles, this type of thing. This is an infection of the nail folds. What do we do for these patients? You're going to do warm soak. You may use Burroughs solution. Okay, that's an oldie but goodie. You may tell them to use acetic acid. What's a non-fancy name for acetic acid? Vinegar. Some water, warm water with vinegar in it. You may IND it. You need to think about MRSA. We know that MRSA loves to live underneath the nails. It's an area that people can get colonized. One of the reasons they get colonized is because they're picking their noses. So you want them to stop biting their nails. They may need to have their nails taken off, this type of thing. Okay. Usually an IND will take care of it, but sometimes you'll use something topical. Okay. What do you think this one is? What does this look like? I tried to get a couple different skin tones on here because this can look different in different skin tones. So what do you think this is? This is Mongolian spots. Okay, funny story. My son, who's 20, after he was born, it was kind of a bit of a traumatic birth. But anyways, I was in the room, and the pediatrician was in there, and they're examining the baby, and they were saying, "Oh, these are Mongolian spots." Well, although my last name is spelled like it's Asian, we aren't Asian. My husband is German, so it was kind of a funny story. The baby actually did have a little bit of a bruise on his back. So Mongolian spots, these are blue or gray. They can be up to 10 centimeters, so they can be kind of big. This can be more common in our populations of color, African American, Native American, Hispanic populations. Usually this will fade by 4 years of age. It can be confused with abuse, and it should be documented in your newborn assessment if you see that. That's really important. Really common in the sacral region. Okay, what do you think this is? Okay, this is cellulitis. So in a patient with cellulitis, the skin's going to be red, it's going to be warm, shiny, usually is acute and spreading. And one of the things, if you're, maybe it started and you're treating your patient, this is when it's really good to use those skin markers, okay? Because you can see if the cellulitis is getting worse. A lot of times when you take a look at the skin, you can't see an open area. You can't treat these type of infections with topical agents. You have to get into, have better absorption of the antibiotic to the underlying structures. So you're going to need to use a PO antibiotic, and if it's severe, maybe even admit the patient and have IV. One of the things you want to make sure you do is make sure you check your pulses, because sometimes a DVT can mimic cellulitis. So it's really important that you check those pulses. In your diabetics, you worry about osteomyelitis, okay, with cellulitis, and you want to be really aggressive in your treatment in areas of poor circulation and in populations that maybe are more susceptible to sepsis. When I say that, I think about diabetes, your rheumatoid arthritis patients on 3 meds, a patient who's on chronic prednisone or immunocompromised. So you want to start your patient on your antibiotic, and you want to recheck in 48 hours. You're going to treat for 10 days or 2 to 3 days after it looks like it's totally gone. And, you know, you want to think about your MRSA, MRSA, BCD, your Bactrim, clindamycin, and Doxy. All right, what do you think this is? What do you think this looks like? This lesion is usually pearly, domed, a nodule. Okay. Common in sun-exposed areas, usually the head, the neck. It's about 40% more common than squamous cell carcinoma. This is basal cell carcinoma. And one of the things when I was putting this together, I was reading a little bit, and I really like this. They said that with basal cell carcinoma, one of the common traits that you'll see is enrolled edge. And it almost does look like, especially the picture all the way to the right and the bottom, like there is like a little bit of a rolled edge there. Real common on the tip of the nose. It's the most common skin cancer. And one of the things you can, you know, to help you remember about a basal cell carcinoma, you think about basal cell carcinoma PUTS, P-U-T-S, pearly, ulcerated, telangiec vessels, and shiny. Okay. All right. How about this one? This poor lady's probably looked at you at so many reviews. There's not a lot of good pictures of this one out there to go from. This is erysipelas. Okay. I want you to listen to my words. Superficial infection of the face. It can be on the ears. It can be on the lower legs too. Superficial. Okay. That means it's non-purulent. Okay. This is often caused by group A strep. How are we going to treat? We treat superficial skin infections with penicillin, your dicloxacillin. If they are allergic, you go with a macrolide. So this is erysipelas. Okay. How about this one? What do you think this is? What do you think? Nobody's going to take a stab at this one? This is orbital cellulitis. Okay. Orbital cellulitis is one of the most common complications of sinusitis. It can also happen secondary to penetrating trauma. With these patients, you may see proptosis. It's Proptosis. And an easy way to remember what that means, the eyes are propped out, protruding. You may see edema of the conjunctiva. These patients, you need to check their IOMs or extraocular movements, okay? You know, because they can have paralysis of the eye muscles. They can also have pain with eye movement. This is indicative of orbital cellulitis. They may have a drooping of the eyelid, and they may have a decreased visual acuity. So there's a couple things you need to do in your assessment. One is a visual acuity. Two is to check for your extraocular movement. These patients, it can be an ophthalmological emergency, and they most likely are going to need to have a CAT scan to be sure that there isn't an abscess formed. Okay, what about this one? This is periorbital cellulitis. When you think about periorbital, this is around the eye, okay? It can be caused by trauma, but it can also be caused by insect bites. You know, I'm from the Northeast, so we have a lot of black flies up here. So especially with the kids, they will, you know, sometimes get a bite around their eye, and it'll blow up like crazy, and they may start to have a little bit of an infection. One of the things that's different, I'm going to have you look at where the redness stops. You can see in this patient that it's going onto the nasal bridge, whereas on the other patient, you can see the redness is isolated right around the eyeball. okay, right in the orbital region. Okay, so this is periorbital cellulitis. This These patients often rarely show any signs of systemic illness. The area is going to be red, warm. They're not going to have that pain when they move their eyes. But this also could be an emergency as well. So this patient may also need to have a CAT scan to see what is going on and to be sure you don't have a big abscess in there. Okay. All right. What do you think this one is? Okay. This is a lesion that if you scratch or scrape, it will bleed easily. This is a big red flag. Common is in lower lip of the smokers, common in sun-exposed area. This is your squamous cell carcinoma, and we know that actinic keratosis is a precursor to squamous cell carcinoma. Okay. How do we remember a mnemonic for squamous cell carcinoma is rubs? Rough, ulcerated, bleeds easily, and scaly. Okay, rubs, R-U-B-S. Rough, ulcerated, bleeds easily, scaly. And the red flag is if you scrape it with the tongue depressor, it bleeds easily. Okay, what do you guys think this is? All right, this is a scarlatina rash. Okay, this is often caused by a group A beta hemolytic strep. Who's at risk? Less than 10. Peak age is 4 to 8. We usually see this in the late fall, winter, and spring. And we think that's usually because the kids are indoors, they're in school. This is also called the second disease, and this is an exanthem of strep throat, basically. So this is sandpaper. If you put your hand on there, it'll feel like sandpaper. It'll be accentuated in the groin. These patients may have circumoral pallor as well. They may have what they call pastille lines too. And that's the picture on the left. This is, it almost looks like the rash is more accentuated in the areas of flexion on the skin. So what do? We generally are going to treat group A pharyngitis. And how are we going to treat? We're going to treat with penicillin or amoxicillin. All right, what do you think this is? This is Lyme disease, also known as erythema migrans. Okay, it may be described as a bullseye rash, a targetoid rash. These patients, just like with the Rocky Mountain spotted fever, they're going to have fever and then a rash is going to develop. So it's so important to ask the patient about the history. This is caused by the deer tick. So this is often seen in the northeast regions. I'm from New York, so we have a lot of this. I'm in upstate, the real upstate New York too, by the Adirondacks. So we have a lot of Lyme here. Usually the rash will appear 3 to 30 days after the tick bite. How do we treat this? Okay, we're going to treat adults with doxycycline. You can do 100 milligrams PO twice a day for 10 to 21 days. For kids, it is still recommended that we treat for Lyme amoxicillin, and that's 50 milligram per kilogram divided by mouth 3 times a day for 14 to 21 days. All right. What do you think this says? This is something that needs to get out of your office. This is a meningococcemia. Okay, this is meningococcal septicemia. All right, remember your meningitis signs. Okay, Kernig. Patients are supine with the knees bent at right angles as the legs are straightened. It causes the leg pain. Brinsky. This is when the neck is flexed and it causes flexion of the hips and knees. Remember with meningitis, cerebral spinal fluid, test is the only way to truly diagnose. Okay. Remember that the meningococcal vaccine is not live. What do you think this is? Okay. So this is diaper rash. Now the one on the left is more of an irritant diaper dermatitis, because you can see it's a little bit convex, and then it kind of spares some of the inguinal creases, and sometimes too the gluteal cleft. That's not the case in this picture, but that's one way to think about it. The patient on the right is a yeast or candidiasis diaper rash, and what I want you to do is look at how the in the inguinal area. This is the picture on the right. It looks red, it looks beefy, but you've got all these little tiny lesions around the big rash. Those are called satellite lesions, okay? And that is a clue to you that you're dealing with a strep infection. What do? We treat this with niacin, miconazole. You want to try to keep the baby dry. There is an old school compound, if you're lucky enough to have a compound pharmacy. If not, you can ask your mom. They can actually whip this up in the kitchen per se, but it's called diaper derm, and one of the pediatricians in our town used to use it. And believe it or not, in the ER we get a lot of parents come in with their children with terrible diaper rash, and this diaper derm compound is equal parts of 1% hydrocortisone cream, equal parts Desitin, nystatin, and Maalox. Okay, so the hydrocortisone helps with inflammation. Desitin is your barrier. Your nystatin takes care of the fungal rash, and the Maalox kind of dries things up. And it honest to God, is like a miracle. I actually had a student of mine ask about that recently because she had lost her recipe per se. So that's a little caveat for you. Okay, what do you guys think this is? Okay, this is rubella, also known as German measles. This is considered the third disease, okay? These patients will have rash and itching that lasts for 3 days. The exanthem, meaning what we see on the outside, on the skin, you'll see erythematous macules and papules that start on the face. Underline that. With rubella, the rash starts on the face, and then it will spread cephalocladal, right down the line. The enanthem is your Forschermer spots. Okay, and Forschermer spots are petechiae on the hard palate. You see this before the rash kind of blossoms. Okay, these patients you're going to see in large post-occipital, retroauricular, and post-cervical nodes. Okay, rubella. All right, just to make your day, what do you think this is? This is rubeola, measles. Okay, this is the first disease. This is caused by the paramyxovirus, highly contagious. We do have a vaccine. We know that it is a live vaccine. We don't give live vaccines until age 12 months. We do not give live vaccines to pregnant women. With the prodrome, you usually will have fever and the 3 C's: cough, coryza, and conjunctivitis. The coryza is a runny nose, fancy name for that. Your enanthem, meaning what you're going to see on the mucosa, is the Klimek spots. Okay, how we remember that is you've got rubeola and Klimek spots. Both have 1 L and 1 O. Okay, one way to remember, what's a Forschermer versus a Klimek spots, and does it go with rubella or rubeola? So rubeola, the enanthem is Klimek spots. Both have 1 O and 1 L. This rash is usually blotchy. It'll be red. It'll be maculopapular. But what is, when you ask your history, it's really important for you to pick up on is that this rash usually starts behind the ears. and then has the cephaloclaudal spread and becomes confluent. So it'll be, you know, there'll be a lot more red than there will be their skin tone, and then it'll kind of all work in together, that rash, and become very confluent. Okay, so remember the 3 C's. Remember your cold spots, and remember what we about the MMR, that we don't give live vaccines to babies under 12 months. We don't give it to pregnant women. All right, what do you think this is? Okay, this is super annoying for parents. This is roseola. Okay, and this is the history again is going to help you with this patient, because your patient is going to have super high fever, 104, 105, 103, and you know, for about 3 days, and then after the fever goes away, baby feels better, think everything's back to normal. This is when the rash will kind of blossom. Okay, these are rose pink. They're kind of almond shaped. You know, this will appear on the trunk. It then will, it's not itchy. The baby's not itching at all, and it will spread rapidly to the neck, the face, the arms, and the legs. So this is caused by human herpes virus 6 or 7, and not much to do for this. You know, this is just supportive care. Make sure that the fluid intake is good, Tylenol, Advil for the fever, and kind of watch and wait. Okay, so the history is really going to help you with roseola. Okay, what do you think about this one? Okay, so you see the little guy on the left, and you really can't see his extensor surfaces. I wish they gave you the whole picture with him. But if you can picture the way his face looks with the really super slapped cheeks, and then the rash like you see on the right hand side on his extensor surfaces, this is what 5th disease looks like. This is also known as erythema infectiosum. Okay, this is usually symmetric. This is this lacy erythematous rash over extensor surfaces. Baby's going to have a high grade. Older children may tell you that they have a headache. They may tell you they have a sore throat. This is caused by the parvovirus B19. Management is supportive. One of the things you need to think about is that if the mother is pregnant, you know, dad may need to take over, or grandma, or whomever, because you worry about 5th disease and exposure in pregnant women because it can cause a miscarriage. So it's really important to keep that in mind too. Okay, what do you think this is? This is Coxsackie. This is also called hand, foot, and mouth disorder. This you'll often see in infants and children less than 5. They're going to have fever, malaise, but when you, what really gets the parents upset is they'll come in because they have the rash on their hands and their feet. One of the things and they may have it around their mouth as well. One of the things you definitely need to do with these little buggers is take a good look in their mouth. And when you think about the ages less than 5, this can be a bit of a challenge in the office, but dollars to donuts, you're going to see these little lesions in their mouth as well. I've also seen kids that have them on their buttocks as well. What do you do for these kids? You're going to avoid acidic foods and drinks. If they're old enough, you're going to have them, you know, do some saltwater gargles. You may use some NSAIDs. You're not going to use aspirin. We know we avoid that because we worry about Rye syndrome, and good hand washing. Okay, what do you think this is? This is zoster. It's also called shingles. This is this rash you're going to see. It's going to predominantly be on the trunk area. It's going to follow a dermatome around, so it will go from the spine all the way around sometimes to the front of the body. And it's almost like there's a line drawn right down their nose, cutting the patient in half where it'll stop. So it'll be a hard stop. It usually will affect one dermatome. These patients may come in and have initially and tell you that they have pain. They may have some burning in the area, and then you're going to see this macular papular rash with some group vesicles on an erythematous base, which is our classic herpes presentation kind of blossom. So anytime you see group vesicles on an erythematous base, you need to think about viral infections like chickenpox, your zoster, your herpes labialis. How would we treat? We're going to treat with acyclovir. And why do we want to do that? We want to treat them sooner than later too. We want to usually start within the first 72 hours because we know that these patients can end up with post-herpetic neuropathy, and it can be very, very uncomfortable for them. So this is zoster. Funny story, I was working in the emergency room, and I went into the room and I'm doing the history. And I'm talking to the patient, and they're telling me, you know, all about their past medical history, and they've got high blood pressure and diabetes, every single risk factor you could possibly think about for cardiac disease. And why they had come in, they were telling me that they had left chest pain. And it was kind of lower, you know, like mid-chest, I would say. With all these risk factors, I'm like, oh, it's got to be, you know, she's going to have to be admitted for observation and serial enzymes and da-da-da. And she's fully clothed. And I said, okay, let me just take a, you know, look at your skin. And sure enough, her chest looked just like this fella. So I asked her, I said, oh, I guess you're testing me to see if I really am going to do an assessment. But she had shingles. Okay. So the patients can come in with chest pain. So make sure you're looking at that skin. All right. What do you think this is? Okay. This is allergic contact dermatitis. This is common right now. Poison ivy. Okay. Usually with poison ivy, lesions are going to appear 24 to 48 hours after your exposure. I've had a lot of this recently because it is the season. People are out, they're gardening, they're hiking, all these type of things. One of the things that you need to make sure that your patient does is make sure that they kind of decontaminate themselves because of the fact that poison ivy, or poison sumac, it's all oil from the plant. So what I tell my patients to do, ditch your Bath and Body Works body wash and bring in that bottle of Dawn dish soap and give yourself a good scrub with that, because that will take the oil off the skin. They also need to make sure that they're cleaning well underneath their nails, because it can kind of hide out there. You're going to treat with hydrocortisone if it's a non-severe case. Your colloidal oatmeal. That's why we love Aveeno, calamine lotion. And if it is a refractory dermatitis, or it's a really, you know, pretty significant where the patient is really having a hard time with it, you may try a course of systemic steroids. Okay. What do you think here? What I think here is, oh, please, dear Jesus, I hope I didn't write the script that caused this. So this is Stevens-Johnson syndrome. Okay, you're going to see the lesions in the mouth and the rash, and just, you know, the lips look like they're melting almost in these patients. There's a lot of medicines that commonly cause Stevens-Johnson's. We write for a lot of them. Allopurinol, carbamazepine, phenobarbital, Bactrim. Okay, these patients can get into trouble super quickly. This is for my acute care nurse practitioners who are part of the APR and Central Tribe here. So this is also called toxic epidermal necrolysis. Okay, so Stevens-Johnson's. Okay, what do you think this is? This is Hemangioma Schoenline purpura, also called IgA vasculitis. This is usually acute, systemic. These patients, they need to be closely monitored, often are admitted. About 75 of these patients will end up with arthritis. Many times will have abdominal pain, and about 50% will end up with some renal issues going on when the disease is acute. In these patients, about 5% of them will end up with end-stage renal disease too. So this is a big deal. If you see a rash like this, and I mean, I think there's a little bit of a theme in this lecture anyway. You saw the meningitis. It was, you know, unbelievable the way that rash looked. You know, if you see with the Hemangioma Schoenline purpura, this is also a pretty nasty looking rash. This is something that you're probably not going to be treating in the office. We're going to be turfing this off to our friends in the hospital, their ER nurse practitioners and our acute care nurse practitioners. This often will spontaneously resolve. We use corticosteroids and immunosuppressants to kind of put this at bay. This can be, they can have some long-standing renal issues after this. Okay. What do you think this is? This is kind of a joke on the left. Okay, this is, you know, a kid with a strawberry in their mouth. But for those of you who are out there, you know, in your clinicals, in your practice, you've seen the strawberry tongue. It looks super bright red. This is Kawasaki. Okay, so you're going to see the strawberry tongue again. Red bloodshot eyes, cracked, dry lips. These kids are going to look sick. They're going to report to you that they've had a fever for 5 or more days. The thing that really gets the parents upset and they'll bring them in will be the fever, but it also will be red swollen hands and feet. And then you'll see that the skin's just like sloughing off their hands and their feet too. The hemorrhagic conjunctivitis also it can be problematic. We're seeing this in kids. This has been going around in our country right now. And we get concerned because this is a viral infection that can affect the medium-sized arteries from head to toe. So these guys need to get punted to the ER and this is probably the one time in kids we don't care about Reye's syndrome. We use high doses of aspirin and IgG therapy when we do that to avoid blood clots from the inflammation in the arteries. So these kids can be pretty sick. So Kawasaki. Okay, what do you think this is? This is a hemangioma. Okay, this is a benign vascular tumor. It's increased by caused by increased growth of endothelial cells on blood vessels. This is often benign. You know, the management often will depend on the size and the location. And in some kids, it will actually shrink as they grow. So often they won't do anything to the lesion until the child is older. All right, name this rash. Okay. This is Alopecia areata. Okay. This is classified as an acute patchy hair loss. You know, your patients often will be really upset, especially our ladies. They really get totally tripped out about their hair, as you'll know. You're going to have to ask some questions. You know, is there a history of hypothyroidism? You know, is there a family history? Are they using hair products? You know, we're using a lot of straighteners now. And you know, that can also cause some hair loss as well. But alopecia areata can be idiopathic. Often you'll use some steroid in the area. Sometimes they use it topically. Sometimes they'll do some injections. Sometimes it goes away just as quick as it comes. Stress can be a trigger too. Okay. I have to wonder if that term, I'm losing my hair over this, is comes from, you know, back in the day. They didn't know. They seem to know sometimes more than what we know, though. All right, what do you think about this? What do you think about this cute little rash? This is molluscum. If you look at it, there's one that's a little bit more flat, but if you look at the lesions, you can see that they are umbilicated as well. And the little ones, this is common. You'll see this with kids. You know, it's itchy. You see it on the face, the neck, the arms, the legs. If you see it in the genital region, that is a red flag for sexual abuse. Okay, so it's not cool if you see that in your kids. If you see it widespread, especially in an adult, you want to think about testing that patient for HIV, because that may indicate that they have a really low CD4 count. How do we treat? Cryotherapy, laser. They also use podophile, a toxin. Yeah, cream. It's 0.5%. And that is not recommended for pregnant women because of presumed toxicity to the fetus. You know, this is a viral infection. There's no treatment. You're going to treat the symptoms. So you may give the patient a little bit of Atarax to stop the itching and to kind of get rid of the fluid. And sometimes, too, people will use a silver nitrate stick and to pop and drain the lesion, too. But obviously, if it's on the face and the neck, you don't want to be cautious. You don't want to leave any scarring. So molluscum contagiosum. All right. What do you think this is? This is like a little makeover. You got before on the left and after to the right. So this is subaric keratosis. Okay, it looks like wax. It looks like, you know, kind of wart-like. Looks like there's paste on there. It looks like, you know, if you're looking at your patient, and many of us nurses love to fool around with lesions. You almost want to like peel this off. Almost looks like you may want to give them like a washcloth to wash it off. Usually black or tan. This is, they call it the barnacles of aging. Usually middle or older age individuals. You see on the chest, the back, the head. You're not going to see this on the palms or the soles. This is benign. You can do nothing about it, or you can do like this guy did and have it removed and go from there. All right. Only a couple more. We're almost there. We're doing good. I get 40 of these disorders in an hour, which is cool. So what do you think this is? This is genital warts. Okay. This we know is caused by HPV. We use the imiquimod, 5% cream, Aldera. That's something the patient can do at home. You know, what can we do as clinicians? We may treat it with cryotherapy. You may use your BCAs or TCAs, your bichloroacetic or your trichloroacetic acids. And if it's very significant and problematic, you may do a surgical excision. So, genital warts, condylomata. Okay, what do you think this is? There's two lesions here. There's one on the left and one on the right. So what do you think they are? Okay, so let's talk about some purulent skin lesions. All right, so a furuncle is a localized abscess. They may call it a boil. Okay, this is a nodule with a pustular center that develops usually around a hair follicle. Okay, that's on the left. That's a furuncle, an abscess, a boil. On the right is what they call a carbuncle. Okay, so basically a carbuncle is an involvement of several adjacent follicles with pus discharging from all the multiple follicular orifices. Okay, So their furuncle, you could think about it, they're a lot more fun because they've got a lot of people at the party. All right. What do you think this is? Okay, this is Acne Rosacea. Now, with everything going on right now in the world, what have we been talking about since March? N95 masks. Okay, I want you to look at this picture. You can almost see, it looks like she has a mark from her face from an N95 mask. Another way to remember acne rosacea is N95 acne. Okay, you're going to see small papules around the nose, the mouth, and the chin. How do we treat? Often we're going to use Metrogel, Flagyl. Okay, you may use sulfa, you may use azelaic acid. Okay, this is acne rosacea. So that's the big 40. We've got 2 minutes to spare. We did great. I hope this helped you. I hope you liked it. And I'm glad you joined us. There are a lot of videos on this page already. There's a much more in-depth, it's called What the Funk, and that's dermatology. There's 50 Shades of Gray, understanding chest x-rays. I've done What Can You Hear Me Now? It's Weber and Renee. There's actually one for those of you who are in school on the new APA, because I know students, it doesn't matter what level you are, APA gives everybody a ton of anxiety, and you know, they may help you out. There are some changes with this new version that have really are making our lives easier. I love it that we can use it all right from the bat. So, but follow us. I try to put some interesting things on Fridays. We have Free Resource Friday. If there's something that you want to share, send it to me. I usually put those up on Fridays. So if you're looking for free CME, do a search of the group and just put resource in, and you'll be able to find that and go from there. I am working on getting my reviews to be on demand because I know you guys really want to have it your way, and that's great, you know, and I understand that because this group has grown so much. We've got people in Canada, we've got people on the West Coast, East Coast, all over the place, all different time zones, so it's hard. So some more to come. Keep posted, and thank you. I hope you have a good evening, and for those of you who are testing, good luck.